Hello and welcome to the show. My name is Portia Monique, and today joining us is the brilliant Dr. Mazare Kamara. She's a highly skilled colon and rectal surgeon specializing in robotic surgery and anorectal disease. She's also a powerhouse, guys, that's saving lives in the operating room as well as breaking down complex health topics to empower our communities. Welcome to the show, Dr. Kamara.
Thank you so much. I'm so happy to be here to talk about all things colon, rectum, and anus.
Yes, we are looking forward to, and we are very excited because we need to be about you dropping these life changing jewels and educating our communities. March, as you well know, is National Colorectal Cancer Awareness Month. So I want to get to that right away, but I still want to know about your journey. What inspired you to pursue your career in colorectal surgery? And what's one piece of advice that you give to aspiring doctors, especially Black women entering the field?
Well, for me, I originally went into medicine thinking that I wanted to be a cardiologist, actually. But then I fell in love with the operating room as a medical student. And I loved that you could identify a problem and fix it in the operating room and have a direct outcome of that intervention. So that
Mm-hmm.
was very appealing to me. And then colon and rectal surgery for me, I also have this very big interest in public health. I think that comes from number one, I'm a first generation Sierra Leonean American. So
Okay.
growing up, I heard all my parents talking about different aspects of healthcare in Sierra Leone. And I guess it really motivated me when people have lack of access and lack of resources. And hearing about those stories, they really resonated with me. So that
Mhm.
was one thing. But then also growing up in the US, not necessarily having access to healthcare as much as my peers or other people in my neighborhood, that
Mhm.
actually led me to just saying, it's very difficult when I had family members that would get sick and ill. And it was very difficult for them to understand what was happening with their bodies and be able to not fear going to the doctor. So, from my various experiences, I said, I really want to do public health also. I want it to be a merger of two. So for
Mhm.
me, colorectal surgery is basically allowing me to be a public health surgeon. Not only do I get to operate and help my patients in the operating room, but then I
Mhm.
also get to speak about different topics that are affecting our communities, whether it's colorectal cancer, whether it's constipation, but all these things are things that we can discuss. So that is why I went into colorectal.
And then, so if you could give advice to aspiring doctors who are aspiring to be like you, especially young Black women, what would you tell them?
I would tell them that you need to find a mentor and you're not alone in your dream. Because sometimes you look around and you say, am I the only one that wants to do this? Or am I the only one that has this aspiration? But I would say, look for mentorship. And in today's day and age, use social media. Some of my
Yeah.
favorite mentors, some of the mentors that helped me get to where I am is from LinkedIn. I basically sent them a cold LinkedIn message and they got back to me because you need to know how they got there. I think a
Yeah.
lot of times people try to build, this from the ground up. And
Mhm.
you need to sit down with people that have done this before, that know how you can get there and
Yeah.
tell you this is the playbook. This is how you win. Because a lot of the times, young Black women might not know, they might not have the access to the playbook, as I call it, the playbook
Right.
of success, especially in
Yeah.
medicine. So
Yeah.
the way that you get that is by networking, getting
Mhm.
mentors, and talking to people.
I love that. I love that. Thank you so much. Now that we got that out the way, let's talk about the basics. Again, March is National Colorectal Cancer Awareness Month. Starting with the basics, at what age should men and women begin their cancer screenings, and why is it so important not to delay?
Oh, great question. So, yes, March is Colorectal Cancer Awareness Month. We are screaming it from the rooftops, and 45 is the age. It used to be the age of 50, but now we're saying 45 because what we are seeing is that more and more adults are getting diagnosed with colorectal cancer. And colorectal cancer is a very deadly cancer. So it is actually the second leading cause of cancer related deaths in the US among men and women.
Mm.
But if you catch it early, then we have a lot of different treatment that makes it a very treatable cancer.
Mhm.
So we say get screening. When you're getting screening, it's because many times early cancers you don't feel that. You don't really know that something has changed in your body or something is happening. But if you get a colonoscopy, that's the gold standard of screening, then
Mhm,
we can identify if you have any polyps or lesions that need to be biopsied and removed. And
mhm,
these polyps can later progress and become cancer. So at the time that we might do your colonoscopy, they might be a precancerous lesion, but then it can develop into cancer. So it's very important that we screen you when you might not have any symptoms, remove those polyps, and decrease your chance of getting colorectal cancer.
So, two follow-up questions for you. Number one, is it genetic? And number two, what are the symptoms if there are any?
Okay, great question. So, number one, is it genetic? Colorectal cancer is actually it's multifactorial. So, yes, there are people that have genetic predispositions or they're more likely to get colorectal cancer and it might run in your family. That's why it's very important. I know a lot of families don't necessarily want to talk about diagnosis or the big C word, the cancers.
Right.
But it's really important to know what cancers might run in your family because if you are at an increased risk, then you should get screened earlier. So it should
Right.
be before the age of 45. But in
Hmm.
addition to genetic causes for cancer, there's also other factors like environmental. So there are a lot of different things and that you can change with your lifestyle that can help that. And then I'm
Hmm.
sorry, I missed your second question.
Um, what are the signs or the symptoms if there
Yes.
are any? Yeah.
The alarm symptoms or the red flags. I would say the main three things that I would want people to be aware of is number one, blood in your stool. So a lot of times people just say, "Oh, it's hemorrhoids," and they put it away and they don't worry about it. And sometimes it very might well be hemorrhoids, but if you
Yeah.
have blood, bright red blood, you have maroon colored stools, you have black stools, you should really talk to your medical provider about this so they can tell you whether you should get a screening earlier or if it's something that is more routine and more common.
Yeah.
Another thing is change in your bowel habits. So,
Mm,
if you're used to having very large, bulky stools, and then you all of a sudden have very thin or pencil like stools, that is just an indication that your stools have changed. And it could
mm,
indicate that something more sinister or bad is happening. The other thing
mhm,
is change in frequency. So sometimes people are saying, doc, I have a bowel movement every morning,
mhm,
like clockwork every morning. And then you become very, very constipated.
mm,
These can all be reasons you might have a mass or a lesion that's pushing on your stool and making it pencil like. And it's also making it harder for you to have bowel movements. So,
yeah.
this is a symptom that you should really get worked up. And then the last thing I would say is unintentional weight loss. So, if
Mm,
you're not even trying to lose weight, but you are losing pounds, your belt size is changing, your pant size is changing. This needs to be evaluated by your physician because it could mean something more sinister.
mhm. Thank you so much for that. So I heard blood and stools, change in bowels, and unintentional weight loss. So make sure that you guys are going out there and getting screened early if possible, but by age 45 for sure. And don't go past 50, right? Because you just should not. So thank you for giving us that information. Now, what are the risks of not getting screened?
So the risk of not getting screened is missing the precancerous polyps. I would say that is the biggest thing. So if you miss a precancerous polyp, it can develop into colon cancer. And then colon cancer, as I said, you have a better when we diagnose it early, when it has not spread to surrounding structures or to lymph nodes or to other organs, that's when our treatments can give you a better outcome.
Mhm,
But if we let those things grow and actually get to be a larger colon cancer that has spread to organs and spread to lymph nodes, that's when we have poorer outcomes. So I would say
mm,
the biggest risk is that you're missing something that could be preventable.
yeah. Now, let's talk about in the Black and Brown communities, right? So we know that Black and Brown communities are disproportionately affected by colorectal cancer. Can you share some statistics and insights into why this disparity exists?
So we do know that among African Americans, colorectal cancer is more likely to be diagnosed, and then we are more likely to unfortunately pass away from cancer and cancer related death. So it's a 20% we are more likely to be diagnosed, and then
Mhm.
40% cancer and cancer related deaths. That is also multifactorial.
Mm.
It goes to our access to the medical system, our trust in the medical system, and then also there are just other factors that lead to the reason that we are not getting diagnosed early. We are not, there are some times where people are actually fearing the exam. So I have a lot of patients, I have family members even who I have talked about this endlessly and they refuse to get a colonoscopy. And I would say for that, even if you don't want to get a colonoscopy, there are other ways that we can screen you. So while
Yeah.
colonoscopy is the gold standard, there are other things like Cologuard, where you give a stool sample and we look for blood as well as DNA
Mhm.
that can tell you if you have polyps as well as colorectal cancer. So there
Mhm.
are other methods. Do not get screening just because you're afraid of having a colonoscopy.
Exactly. And to your family members, not only are they not listening to their doctors, they're not listening to you, and you give them the best expert advice. That is,
Yes, but I think when it comes, we need to recognize, especially historically,
yeah.
there is a mistrust in the medical care system. And it's
Mhm.
there, and we cannot say that people shouldn't feel that way. There's
Exactly.
a reason.
Right.
There's data. There's history. We know why that fear is there. But
Mhm.
now it's about combating the fear and saying we don't want to miss something when we can help you. And I think that is what the message that I want to get across.
So you just spoke about access to healthcare and access to some of the facilities that people don't necessarily have them. But what role does systemic barriers such as the access to healthcare and cultural stigmas around screening play in health outcomes of especially Black and Brown patients?
It has detrimental effects. So when you have these systemic barriers, especially, so let's just use the colonoscopy, for example. It's just that same cycle. We are getting later diagnosed because people are actually presenting with more severe symptoms. So instead of, maybe just a little blood in their stool or change in the bowel habits, those earlier signs, people actually might present with significant bleeding requiring blood transfusions and found to have a very large colon and rectal mass that is bleeding profusely. Or they have a colon cancer that has grown so large over time that you can think of your colon as a tube. And if we hold that tube and block off the end or obstruct it, then we can actually get a perforation, and people can get a perforation of the colon and or the colon mostly. The rectum does that do that as much, but a perforation of that colon, and that can lead to even worse outcomes where people need emergency surgery. And you also have that risk of spreading all those cancer cells around your abdomen. So it's just about that late diagnosis. When we have the systemic barriers and we do not get the appropriate early care, we are unfortunately left to deal with very significant burden from the disease that could have been avoided.
Yeah. And so my question to you when you were explaining that is at that point in time where they have massive bleeding and or a massive blockage, they have to know that something is wrong, right? So is it have you seen that they wait exactly to that point where they can't go on to come to the doctor to get the screening and then the diagnosis is grim from there?
I think that also there are so many reasons. Sometimes what I'll see is family members have been telling an individual, and a lot of times it's the wives have been telling their husbands
Yeah.
for a long period of time, you should get that checked out, you should get that
Yeah.
checked out, and they
Yeah.
don't. And
Yeah.
it's because maybe they can't take off from work, or
Yeah.
sometimes it's just fear. Sometimes people know something is wrong and they
Yeah.
are afraid to face and confront what this possibly could be.
Yeah.
And sometimes it's just the fear of that. And then other times you'll see, unfortunately, people have lack of insurance or lack of
Mhm. Mm.
um, other health
Benefit.
necessary resources.
Yeah.
And then as a result, they're not coming in until too late.
Okay, so as a community, what steps can we take to increase the awareness and encourage preventive care among our communities?
First, I would say number one, talk about your family history.
Mm.
We should not see this as a topic that is very private that we don't want people to know. It's important that we know because then that is helping us to stratify risk in the family.
Yeah.
I think
Yeah.
that's the first thing. The other thing is just knowing the when and the where. I want everyone to know you get colorectal cancer screening starting at the age of 45.
Mhm.
45 and earlier if you're high risk and you have a family history.
Mhm.
And that screening can be a colonoscopy. It can also be Cologuard, but you want to get screened to catch these colorectal polyps early.
Yeah.
And then I would say the last thing is we should really much talk about the prevention that's possible. A lot
Mm.
of things, lifestyle modification. So I'm talking about getting increased fiber. Colorectal surgeons love talking about fiber, and I can talk about that a little bit more. But
Mhm.
fiber is essential in your diet. We should be getting 25 to 35 grams of fiber a day, and the American diet is terrible when it comes to the amount of fiber. And then we should be active, physically active. You
Yeah.
really want to have 30 minutes of physical activity a day, and walking should not be poo pooed on, for lack
Right.
of better terms. I want,
No pun intended. No pun intended.
no pun intended, but um, people sometimes think they have to be doing a hardcore workout at the gym, lifting the weights and doing all the things. But if you are just walking,
Mhm.
that in itself is helping you prevent a lot of different diseases, not just
Yeah.
cancer.
Yeah. Now, I do want to touch on that just a bit later, but I want to get to if someone has an unfavorable screening result, what are the next steps that they should take?
Yes. So when you have an unfavorable screening result, you really want to go in to see your doctor because it depends on what we find. There's a large range of things. So unfavorable could just be that you have a polyp that was precancerous. And we say,
Mhm.
okay, you have this precancerous polyp. And now, depending on the features of the polyp, because we send it to the pathologist, they look at it under a microscope and they tell us different things, whether it's size or how deep the polyp was. Those
Mhm.
things can tell us how soon you should get your next colonoscopy. So it's
Mhm.
really important to
Mhm.
first go review your results with your doctor so they can tell you when your next colonoscopy is. But then let's say they do find cancer. If they do find cancer, great. I say great because now you know early and now we can do things to get you treatment. And
Mhm.
then you would do a workup. The workup is going to consist of imaging, so getting CAT scans, looking at your chest, your abdomen, and your pelvis.
Mhm.
We also get blood work. And that helps us to know has the cancer spread to anything else?
Mhm.
And then what is going to be the best treatment for you? And treatment for colorectal cancer can include chemotherapy, radiation. It also includes surgery, of course. And then we also have very new immunotherapies that are available as well. So there's many treatment options that are available. And if we find it, we can treat it. So if it's unfortunate that that is your finding on the colonoscopy, I want you to know that we partner with you and we work with you to make sure that we can get you the best treatment possible.
Wow. Well, thank you for that. Now, let's talk frequency. How often should we be getting those? Let's just say we had our initial one. When is the next one due? And then if we had a favorable result, how often should we be going?
Yes. So it all depends on what they find on the first one. So that's why
Okay.
we say you get it your first one at 45, and then depending on the number, size of the polyps, and other features that the pathologist might find, will then tell you that you're on a 10-year schedule. 10 years would be we found nothing. It looks perfect. You can get your next one at 55. But then some people need to be on a 5-year schedule, and that's if they have history of their own personal polyps or they have a family history of
Mhm.
colorectal cancer, then those
Mhm.
people would get one every 5 years. And
Okay.
then also, depending on the other findings that we have of if we do find polyps, again, how large they are, how deep they penetrated into the colon, the number of polyps, we might put you on an even shorter surveillance or the next time that you should get your colonoscopy. So
Mhm.
45 to start, but we can change it from there. If it's perfect and clean, the next one would be 10 years.
Wonderful. Now, I do want to touch on your specialty because I think that's important. When you go to school and you put all those years in and then you practice a specialty, I like for people to talk about that, right? So, you specialize in robotic surgery. Can you break that down, what does that mean for someone who might be apprehensive about tech medical procedures?
Okay. So I would say I'm going to back up just a little bit just to make it so people can understand just a
Yeah.
little bit there. So, number one, robotic surgery is a tool, and it's a tool that I specialize in using,
Okay.
but it is across a lot of different specialties. So, I would
Mhm,
say I specialize in colon and rectal surgery. That is a subset of the different surgeries that people can have, whether it's general surgery, hepatobiliary surgery, the list is endless.
mhm,
Um, but then in colon and rectal surgery specifically, the robot is a phenomenal tool that can help us give better care to our patients. And the reason being is the colon and the rectum, really, that rectum is in a bony pelvis. So your bony
mhm,
pelvis. And basically, it is very tight space and it's a very difficult space to work in. When we use the robot, we get magnification and then we can also do very fine movements that allow us to better deliver care and be able to take care of very complex pathologies.
mhm,
It also allows us to make smaller incisions. So sometimes we have to make what we call an open surgery. You have a very long incision on your abdomen. But
mhm,
with robotic surgery, a subset of minimally invasive surgery, we make
mhm,
smaller incisions. And if you
mhm.
think about it, small incisions means less pain. It means that it's better recovery for our
Yeah,
patients.
yeah.
So I would tell patients when you're a bit apprehensive about the tech, you still have your surgeon. It is not the robot doing the surgery automated with I sit at a console and I
Mhm.
control the robotic arms in
Okay.
order to do this surgery. So you
Mhm,
still have your surgeon and you should just think of the robot as a tool that allows us to deliver better care for you.
mhm. Now, what insurance do you take? Because I know if I have an issue, I'm I'm coming to your hospital and I'm gonna make sure I ask specifically for Dr. Kamara because that part. You don't have to answer that. I'm just saying.
I take that as a big compliment. Thank you.
Mhm. You're welcome. Now I do want to talk about the role of nutrition and lifestyle, right? So you said earlier, live an active lifestyle, get that fiber in. We often hear that food is medicine. What are some key dietary habits that people should adopt to lower their risk of colorectal cancer?
Okay, I'm gonna start with fiber. The American diet is terrible. We do not get enough fiber. And I want people to think about fiber this way. Your stool is basically the waste. It's the waste. Your body has already picked up all the nutrients, all the water, all the things that it needs. So this is waste. It's toxic. It's passing through your colon, and you
Mhm,
want all of it to pass through in a nice, smooth bowel movement that clears the colon from basically having these toxins being exposed to your colon wall. Okay,
mhm,
so let's think about
mhm,
it. Poop is toxic. We want the poop to come out. The
mhm,
way that we need the poop to come out is if the poop is bulky, and you're basically having a nice, smooth evacuation, and we don't leave any sticky residue on the walls that can basically be toxic to the colonic mucosa and
mhm,
cause something like cancer down the road.
mhm,
So, eating fiber bulks your stools. It lets you have more frequent bowel movements and gets all the toxins and waste out of your body. So,
mhm,
that's why I say fiber 25 to 35 grams. Everybody needs it. The things that have fiber, we're looking at fruits and vegetables. We're also talking about seeds and nuts,
mhm.
a lot of grains. Those are the things that are going to increase your fiber in your diet, allowing you to have more frequent bowel movements, and basically fuller and bigger bowel movements to get the toxic waste out of your body.
Now, besides diet, what lifestyle changes, exercise, hydration, stress management play a role in maintaining a healthy colon as well?
All the things that you just said, exactly. So you
Mhm,
also want to get enough water. When you take in that fiber that I just said, it you can think about it as a sponge. If you do not have enough water, then the sponge is basically a hard sponge that you're passing through your colon. So with the water and the fiber, that's how you get that good bowel movement. You should
mhm,
be drinking 60 to 80 ounces of water a day is about what we recommend. Now, in addition to the water, the other lifestyle things is exercise, exercise, exercise. When you move, your bowels move. So a lot of patients come in and they are constipated, and it's just like, how much are you walking? How much are you running?
Mm-hmm.
And we have to work up to these things. Again, as I said, do not think get out there and do the hardest workout ever. Just walk. Just start
Just
with
one.
walking
Mm-hmm.
at an easy pace.
Mm-hmm.
So that is something that we should definitely do. So I would say the lifestyle changes, I would say fiber, water, and making sure you get enough exercise. The other one that I want to include, minimizing red meats and processed foods. So we
Mm.
also know that red meat, processed foods, these are carcinogens, or basically they're cancer causing agents. And now, don't get me wrong, I love a good steak, and I'm going to enjoy my steak.
Mm-hmm.
However, you want to just limit things. A lot of things are in moderation. So limit the amount of red meat that you're getting and the processed foods.
Okay. Well, love that. Love that. Before we wrap, I do want to give you a chance to speak about your journalism and your health literacy because you've dedicated part of your career to medical journalism. How does storytelling and education help improve health outcomes, particularly in communities that lack access to quality health care?
I think thank you so much for highlighting that. I
Absolutely.
am currently on a mission of getting this information out, and I want to meet patients where they are. So sometimes it's not necessarily in today's day and age on the news and in that kind of media, but actually social media. So on Instagram, my Instagram is at Dr. Kamara. I talk a lot about colon, rectal, and anal health, your gut health, and different things so that people have more access to this information.
Mhm.
And it's an attempt to make it kind of fun, quick, and educate you when you're on the go.
Yeah.
I think it's very important because number one, people are getting all type of information from different venues and different avenues that might not necessarily be evidence based. And especially if you, so I want people to get it from a professional, and that's where everyone should be getting it from a
Absolutely.
professional that has the data, and this is data backed evidence, and it's not just hand wavy things that we think might work. It's what we know works from the data. So I think
Mhm.
that's important. And then the other thing is just, again, meeting patients where they are, getting the information to them, whether
Mhm.
that's with social media, whether that's going to churches, whether that's going to the nursing homes, which I've done. It's doing different things to meet patients where they are and get them the information so that they can feel that they are empowered by this health information and that
Mhm.
healthcare is happening for them and not healthcare happening to them.
Right, right. And kudos to going to the um I wanted to say old folks home. I have her cut that out.
Nursing homes and
The
nursing
nursing homes.
facilities.
Okay.
Yeah.
So kudos to going to the nursing homes and helping out our senior citizens because we know that they need it as well. Kudos to you overall for simply wanting to educate our communities, make sure that we are knowledgeable enough to make an informed decision on our health care, right? So we appreciate you for that. Now, second to last question, because I think this is a very important question when it comes to simply having the conversations around bowel movements, right? So, how do we normalize those conversations about bowel health and make topics like poop, digestion, and screenings less taboo?
I think it's just about talking about it. Once we start talking about it and realizing how your poop is actually a reflection of your gut health. It's, you can just see it as this is an internal, it's an outward expression of what is happening on the inside of me. And the thing is, we all poop. We
Yeah.
all poop. So we shouldn't be afraid. It shouldn't be a dirty or a bad word or a bad thing. You want to know what a normal poop is too. That's something that we could get into another time, or this time,
Yeah.
whatever you see appropriate.
Mhm.
But you want to know what a normal and a good poop is. I call it a perfect poop, and the criteria for that. Because until we actually know that, we don't even know what is supposed to be happening with our
Right.
bowel movements. And I'll be honest, it wasn't until I was in, this intense colon and rectal surgery fellowship that I realized, wow, I'm not even, I was constipated. I did not know I was constipated
Mhm.
until actually learning about it. And now I'm like,
Mhm.
this is a good bowel movement. That was a good bowel movement. Or no, I really need to take in more water. I need to drink,
Mhm.
eat more fiber.
Mhm.
So these are just things that with education we can improve on a daily
So,
basis.
so I don't want to leave without knowing what a perfect bowel movement is or a good bowel movement. So please enlighten us.
Okay, so a perfect poop. Number one, it's a quick drop off. So when you go into the bathroom, you should not be straining and pushing and trying to get it out. That is telling us that you are constipated and you cannot get that out.
Mhm.
Um, the other thing is that you want to have a very good consistency of your stool. So it should be like a sausage like bowel movement or a snake like bowel movement rather than having pebbles come out or at worst having some diarrhea and very loose watery stools.
Mhm. Mhm.
You also want it to be a one wiper. So that means the first time you wipe, it's you might have some mess on the toilet paper, but the second time is nice and clean.
Mhm.
So that just tells us if it's hard for you to clean up on the outside, think about that as stool just being all along your colon wall and hard for it to get out of your body too. So
Mhm.
that's an indication of that. So those would be the criteria for a perfect poop.
Now, and I know I said second to last question, but you spurred a thought in my mind. What are your thoughts on colon cleanses, colonic cleanses? Are they safe? Should we be doing those? What are your thoughts on them?
So some of these colonic cleanses, I hate to say it because everybody's so passionate about them. They have not, it's not evidence based. We have not seen that those actually are helping our patients. So
Mm,
that's why I would say go to your doctor and we can review these on, you know, a medication by medication basis because a lot of
okay.
them are not FDA approved. It's just
Mm,
some cocktail that was uh, put together. So sometimes I'll review ingredients, if someone brings this and they say, "Yeah, I'm reviewing ingredients," that helps. The other thing is you want to really be careful, especially if things are you're putting it into your rectum or putting it into your anus. Um,
mm-hmm,
you can get a perforation.
mm,
So you can get a hole in your rectum, and we see
mm,
that quite frequently. And then also the other thing to be worried about, so in addition to putting in getting a perforation, you don't want to necessarily put things into your rectum that is going to have a negative or toxic effect to you. So
mm,
be very, very careful about, a lot of these colonics. I would say review them with your medical provider. Don't just trust the commercial.
love it, love it. Okay, last and final question. I was trying not to go long, but what's the one message that you'd like everyone to walk away with from this conversation about colorectal health?
I would say number one, it's going to
Go,
be
go for it.
I'm trying to say what I think is the most important one, but
Mhm,
in the case that this is Colorectal Cancer Awareness Month, I would say I want everyone to know 45 for a normal risk patient is when you should be getting your colorectal cancer screening. Colonoscopy is
mhm,
the gold standard.
mhm.
Is what I would want the takeaway to be.
I love it. Thank you so much for your time. You gave us your handles before, Dr. Kamara. Is there any other way that we can follow your journey? Your website, perhaps? Make sure that we are up to speed and up to date on what it is that you're doing.
Yes. So my website is www.kamaramd.com. You can also follow me there. And also, there are links where you can see my past talks as well as if you want to book me for a talk.
Okay. And then I heard you say earlier LinkedIn. So are you active on LinkedIn as well? Okay. So
I
we'll
am
make sure.
active on LinkedIn, so you can find me there under my name, Mazare Kamara.
And then what about TikTok? That's how you reach the young folk.
Let me tell you, I am not fully into TikTok yet. I am in on Instagram, so
Okay.
that's where you'll see a lot of my reels.
Mhm.
But we'll see. Growth in the future. I'm trying to move to other platforms as well.
Growth in the future. Thank you so much for your time today. We certainly appreciate you coming on in light of colorectal cancer screening month. We are going to make sure that 45 and the gold standard is
Colonoscopy.
colonoscopy. We appreciate you. Take care, Dr. Kamara.
Thank you so much.
Thank you.